Good morning, everyone, and thank you for joining us for today's webinar on vaccine distribution, manufacturing and distribution in the United States, and more importantly, in the state of New York. My name is Stephen Aquario. I'm the director of the Association of Counties. And again, thanks for taking some time, and thank you for our panelists today for taking time in their very, very busy schedules collectively to be with us. COVID-19 vaccine candidates we've been seeing on the morning and evening news and throughout the day. These candidates have shown great promise in their studies and could be approved by the FDA and other federal government jurisdictions, hopefully by the end of the year. After a vaccine is approved, manufactured, federal, state, and local governments, of course, will need to be working together to get the vaccines delivered, stored, and administered to those who will receive it in the various phases of distribution. And as I heard a phrase today, a vaccine doesn't save lives, vaccinations do. I really like that line, and it stuck with me, and it meant something to me, meaning that we have to effectively administer these vaccines in a professional manner. In a moment, we'll turn it over to our NISAC president, the Honorable Jack Marin from Ontario County, to introduce our great panelists this morning. But before I do that, I just want to give a quick shout out and a quick thank you to Salesforce. And Maureen Hagan from Salesforce was generous enough to step up and help sponsor this webinar. Of course, Salesforce is an associate partner of the New York State Association of Counties, joining as an associate partner during this year. And without the generosity and support the private sector, we wouldn't be able to have these types of forums. So let me give opportunity to Maureen Hagan to say a few things, and I believe she's got a very short video that we want to show. Maureen Hagan from Salesforce, I'll turn it over to you.
Thank you, Stephen. Yes, I'm Maureen Hagan with Salesforce, as you mentioned. Salesforce, for you all that don't know, is a cloud-based software as a service provider, and we're the global leader in customer relationship management software. And it helps both governments and businesses enable digital engagement. As we know, the global pandemic has challenged all of us and disrupted every industry. So early on, Salesforce responded by customizing our platform for contact tracing management named Work.com. And Work.com has now been implemented successfully across many state and local governments. It then became clear that a similar comprehensive solution would be necessary to facilitate the vaccination distributions as those became available. And so the logistics required to successfully execute this large mass vaccination campaign, the largest in history, are extensive, which will unfortunately probably overwhelm many in-place vaccination management systems. So the good news is that the cloud is perfectly developed and is what excels at being able to handle these solutions at scale. So Salesforce has collaborated with the CDC to develop Work.com to be that efficient, secure vaccination management platform. It's a fully integrated solution that can support your data management and communications at any scale and can be spun up in a matter of days. So please take a look at this short video of Work.com Vaccination Management by Salesforce.
Building on Salesforce Work.com, which is already deployed by cities, states, and companies around the world to help make their workplaces and communities safe, Work.com for Vaccines will help governments and healthcare organizations more safely and efficiently manage vaccine programs at scale. With Work.com for Vaccines, customers will be able to design, build, integrate, and manage their vaccine programs end-to-end with a platform that is trusted, flexible, and can be deployed quickly. As vaccines become available, people can easily find helpful information and schedule their vaccinations, which provides governments and healthcare organizations with the information needed for forecasting and administration. When they arrive for their appointment, clinical staff can access the person's record, which provides a full 360-degree view of their COVID-19 immunization history and health information. Clinical staff can then leverage information with the latest public health guidance, making it easier to follow best practices and offer great care. And they can update the person's record to reflect any administration information and dosage specifics. Key metrics from these processes provide health officials with insights into the progress of their vaccination programs. Those insights can then be quickly turned into action around things like reported health concerns, supply availability, and vaccination preparedness. Learn more about how to design, build, integrate, and manage your vaccine programs end-to-end with a platform that is trusted, flexible, and can be deployed quickly with Work.com for Vaccines from Salesforce.
And I want to thank Salesforce and Maureen Hagan for being part of this and helping us launch this program today. Dr. Messonnier, very appreciative to you, to the State Department of Health for joining us here today. Laura Santelli, Sarah Ravenhall from the county health officials. Exciting day, lots to talk about. Let's get at it. Jack Marin, over to you, sir, and let's hear who we have with us here today. Thank you, Jack.
Well, thank you, Stephen. Good morning, everyone. I want to thank you all for joining us for a very special and timely webinar this morning on the nation and state's plan to distribute the COVID-19 vaccine. We are joined today by a very special guest from the federal government. Dr. Nancy Messonnier is the director of the National Center for Immunization and Respiratory Diseases, my apologies, NICER for short, and is currently leading CDC's efforts on the COVID-19 vaccine. In late 2019, Dr. Messonnier directed NICER to activate a center-based response to an unknown respiratory disease in China that later transitioned to a full agency response to the COVID-19 pandemic. In the COVID-19 response, Dr. Messonnier is leading the effort to support the COVID-19 vaccine program in the areas of distribution, administration, implementation, safety, and access for hard-to-reach populations, with the goal of ensuring that a safe and effective COVID-19 vaccine is available to every American who wants one. We are also happy to be joined by Loretta Santilli, who is the director of the Office of Public Health Practice for the New York State Department of Health. Laura has 26 years of experience with the New York State Department of Health, including epidemiology, emergency preparedness, and immunization. She has been involved in various aspects of the COVID-19 response and is the Department of Health's ambassador for the state's COVID vaccination plan. Laura is joined by Dennis Whalen of Northwell Health and Kristen Proud from the Department of Health's Commissioner's Office, who are assisting with the design and implementation of the state's comprehensive COVID vaccine administration program. Finally, we have the pleasure of having Sarah Ravenhall, Executive Director of the New York State Association of Counties Health Officials, on today's webinar. NYSACO is a nonprofit membership association representing all 58 local health departments in New York State. I want to take a moment to thank all of you for joining us to share your expertise and experience with the county membership who have joined us for this valuable webinar today. Dr. Messonnier will present first. We will have an opportunity to ask a few questions at the conclusion of her prepared remarks before she has to jump off. If you have a question during any of the presentations, please type it into the question panel on the right side of your screen. NYSAC staff will coordinate the Q&A session at the conclusion of the presentations. Again, thank you for being with us today. We hope that you find this presentation helpful and educational. At this time, I will turn the presentation over to Dr. Messonnier.
Good morning, and I appreciate the time to talk to you here today. I want to go back to something Stephen said about the difference between vaccine and vaccination, which I actually also agree is a great phrase. It's great to see in the news today the data on Moderna and Pfizer's vaccine reported, although of course scientists have not yet had the ability to look at that data themselves. It is very promising in terms of both effectiveness and safety. But my other phrase is that a vaccine that's sitting on the shelf has 0% effectiveness. It is all about delivery of the vaccine. And, you know, we are in unprecedented times, and we are, all of us, being called on to do things that are frankly unimaginable. Although we have talked for years and years about pandemic planning, I don't think any of us exactly could have predicted the position we find ourselves in now, which is smack in the middle of a pandemic. And I can't imagine all of you and the work that you need to do day to day to respond to the urgency of the pandemic. And yet I need to ask you at the same time to be putting in place the pieces now to get ready for this vaccine, because none of us want to waste a day not administering a vaccine that could really turn the tide and save people. My goals today are to give you a general idea of the approach to distribution, but frankly also to demystify some of the things that are being said about the vaccine, because in the end, this is not so different than any of the things that you've planned for, and not so different than the routine work of administering vaccines. It's just sped up quickly and with urgency and lack of ability to do some of the careful planning that frankly we all expected to do. So that's one goal, hopefully to demystify some of this. And the other, I hope, is to make you see that there's a tremendous opportunity and that the hurdles that are in front of us are manageable, and that we really just have to put our noses down and manage them. There's really no choice. So with that said, this is a cartoon meant to show the multi-components of vaccine implementation. The public health impact relies on rapid, efficient, and high uptake of a complete vaccine series. For most of these vaccines, it's 2 doses, with a particular focus on those at increased risk for severe COVID-19 illness. So if you start on the left, the prioritization of populations is a really important issue, because we know that there will be limited supplies of vaccine. We expect the first vaccines to be available in December, but in December, and frankly, for the first several months, we expect limited supply. Prioritization will be really important. There have been a variety of discussions about prioritization, including the World Health Organization and the National Academy, but those conversations have been in the abstract. They've been not knowing the characteristics of the vaccine, and frankly, not really tied to the current epidemiology of disease. And what our advisory committee on immunization practices is tasked to do is to bring all those things together and make specific recommendations about these specific vaccines. That conversation will be continuing at the ACIP meeting on Monday, and frankly, it is going to be a difficult situation with limited supply to try to balance all the competing needs. Allocation of vaccine in general will be pro rata. That means by population size. And that means that, again, with limited supply, some people are going to have to wait. And I tell you all that I know that for those of you at the tip of the spear, this is going to be really difficult. There are people who are going to have good reasons for wanting the vaccine, who are not going to be first in line, and it's going to be difficult for all of us. The vaccine distribution in this setting means sort of just the movement of the actual vaccine from place to place. And for those of you who were with us in H1N1, you will recognize the distribution systems. It's a centralized distribution system. One of the pharmaceutical companies, Pfizer, has contracted themselves for a distributor, but it's being managed identical to the rest of the vaccine. So it's centralized distribution, which then allows us to make sure that the vaccine kits, that is the needles and the syringes and the diluent and the gloves, all match up with the vaccine so that it's delivered as a common package. And the state health departments are in the center of this. We are giving prioritization, we are providing technical expertise, but in the end, it will be the state that sets the plan for that state about where exactly the vaccine is delivered. Administration of this vaccine, these vaccines are not optimized for use in general providers' clinics, right? We know the characteristics of the vaccine that works best for everyday vaccines. And these vaccines, especially one of them, requires ultra-low cold chain. It's not perfect. It's not what we would have wanted, but it's workable. It needs dry ice. We have to have special containers to transport it. Don't be daunted by the challenge. I think we're up to it. For that vaccine in particular, it means that we have to bring people to the vaccine as opposed to farming the vaccine out. The Moderna vaccine, which also we expect to be authorized next month, in December is a little more flexible and frankly can last for 30 days in the refrigerator, the company just announced. So that will be more flexible. And finally, it is going to be incredibly important that we monitor the safety and effectiveness and uptake of this vaccine. These vaccines are going to be licensed based on safety data, efficacy data, but the number of people who get vaccinated in trials is always less than when we roll it out in the whole population. And so we're going to want to have those systems in place, monitor the vaccine, both to make sure that it is in real life as effective as it is in studies, but also as a promise to the American public that we're going to be really keeping an eye on this. The second dose is important because you can't interchange the vaccines. And all of this needs to be underlined with a knowledge of the importance of communication and education for these vaccines. And you all are really key to that. Next slide. This is a cartoon, but meant to make the point about the fact that there are going to be different phases of vaccination. This early phase is this dose limited phase. And we expect this to go on for several months. And in the setting of a limited supply of vaccine, we're going to have to target administration in a much more careful way than we've done, for example, in other vaccines that we use routinely. And this is where micro planning comes in. We're asking the State Department to, at a much more granular level, figure out how the vaccine should be used in this jurisdiction. And we're at the CDC working to try to provide some options that states could use to reach populations. For example, long-term care facility residents are a population that we know is at higher risk. Their lives have been dramatically changed since the beginning of this pandemic. There is high morbidity and mortality in those groups. But frankly, they're a little harder to get to because they're in a long-term care facility. They're not coming out to go to their healthcare provider's office. So we've done a partnership with several long-term care pharmacy chains to try to ensure that we have options for states about how to reach those. And those long-term care facilities, these pharmacies can actually go mobile into the long-term care facilities. We think it's a great option for the health departments because it's one thing you can kind of take off of your plate. But we're not going to be launching that option in New York until the health department tells us to launch it. At some point in the spring, late spring to the summer, we're going to expect much more large quantities of vaccine to become available, especially as a third and hopefully a fourth vaccine come online. When we get to that stage, our challenge jointly is going to be, how do you move out large quantities of vaccine all at once? We're not used to operationalizing that quickly. Hopefully by then there'll be a groundswell of support for the vaccine, so there'll be lots of people who want it. And our challenge is going to be to ensure that it gets out to every corner of the population. And we'll be asking health departments especially to help ensure that some of the vulnerable populations, for example, people in congregate settings, but also populations that we know are harder to reach. For example, there are disparities in influenza vaccination. People of color have lower flu coverage. We want to ensure that we're thinking in advance about how to operationalize in those communities. And finally, at some point, I know we're all looking forward to getting to this third phase where, this is sort of more routine strategy. Next slide. So I'm going to go back to this again, that there are some critical populations that we want to make sure we think through access to vaccine for. And these are in different categories, and we sort of call them all critical populations. There are people that are considered critical infrastructure, like healthcare providers, but also police and firefighters. There are people who are at increased risk for severe illness, like people in long-term care facilities and older adults. There are people at increased risk for COVID-19, for example, in prisons and jails. But also there are people on the right with limited access to vaccine. Now, cost shouldn't be a barrier, but there are certainly groups that have limited access. And we really need to be thinking in advance about all these groups. Success for this vaccination means rapidly getting high vaccination coverage across every sector of our population and every corner of our communities. And I know it's a heavy lift, but we're only going to be able to do it through a whole of community outreach and a whole of community effort. Next slide. I wanted to just go back to vaccine safety because I think there's a lot of questions about this. So the clinical trials for the vaccines, Moderna and Pfizer vaccines, are of the same size and scope as any vaccine that's licensed for use in the United States. I think people misunderstand Operation Warp Speed to mean cutting corners on the size of the trials, but that's not true. In addition, the pharmaceutical companies have a data safety monitoring board who are outside independent experts that review that data. And then the vaccine goes to FDA, where in public, their advisory committee reviews the data, and the FDA staff reanalyze all the data themselves. And then it comes to CDC's advisory committee, where we review the data, safety and effectiveness in real time. And all those things are checks and balances that are put in place to, frankly, reassure ourselves, but also reassure the public that we're doing everything to ensure these vaccines are safe and effective. But we don't stop when the vaccines are licensed or authorized. As soon as these vaccines roll into the population, we put in place our existing systems to monitor safety. We've also really enhanced those systems. We've looked across our whole scope of systems and said, where are the holes? Where are the places where we don't have as strong systems as we want? Let's enhance those systems. We have new platforms. And we have a specific system called VSafe, which is an active surveillance system that we're going to be deploying as soon as the vaccines are launched to really make sure that there's nothing untold happening. And finally, we need to be communicating clearly on the vaccine safety process and the systems now, and to be looking at that data in real time. And we're going to be doing that through our advisory committee, where we've stood up a specific committee to be reviewing this data every week, to hold ourselves accountable, and also to have a mechanism to ensure that the public is seeing that data in real time. Next slide. You can just click through all of these. Vaccine confidence, as you all in New York know, remains an issue. And several years ago, actually, partly in response to the measles outbreaks in New York City and New York State, frankly, we've looked at our approach to vaccination hesitancy and realized that we really didn't want to keep talking about vaccine hesitancy. We needed to talk about vaccine confidence. And so we developed a framework. We deployed it last year. In the setting of COVID, we've looked at that again and realized that most of the principles we think resonate and are right. However, we've really tailored it to try to talk about our current problem with COVID vaccine and the with COVID disease and the COVID vaccine. So this is a national strategy to reinforce confidence in COVID-19 vaccines. I want to be clear that it is not a campaign. It is a strategy, and it's a strategy that's going to take all of you working with us to try to do what we all want, which is to make sure that people have confidence when they queue up to get the vaccine. So the principles are to reinforce trust. We need to regularly share clear and accurate information and take visible actions to build trust in the vaccine, but also the vaccinator and our systems. We need to empower healthcare providers. When you ask people, they still say that they trust their own healthcare provider the most to help them make healthcare decisions about vaccination, or they trust family members who are doctors. And I'm concerned that I'm hearing some hesitancy among healthcare providers, primarily, I think, because they don't have the accurate information about these vaccines. We really need to be promoting confidence among healthcare personnel in their decision to get vaccinated and to recommend vaccine to their patients. And I'm not just talking about the doctor or even, frankly, the nurse. I'm talking about the entire healthcare system, from the clerks that greet you when you come into the doctor's office, the pharmacists, everybody in the healthcare sector. We need to build that sense of trust among all of those partners. Finally, we need to engage communities and individuals. The action here is really at the community level. Communities need to be engaged in a sustainable, equitable, and inclusive way to use two-way communication, listen, increase collaboration, and build trust. And I cannot do that sitting in my house in Atlanta, Georgia. That is the work of you all on the front lines of this in your counties. it is going to be really your counties and your states and your cities that need to be working to identify who the opinion leaders are in your communities and to engage them early and often in this process so that they have confidence not just in the end product, but in the process that you're using to get to it. It's the work now that you're going to do to empower those communities that's going to lead to the result that we all want, which is vaccination coverage. Next slide. Try to end with a what you need to know slide, because I know that I'm giving you a lot of information, and frankly, I could talk 3 times as long and not give you everything that I think you might want to know. But here's my top line messages for you. We are in a complicated vaccine landscape. There are many types of vaccines in development that could be authorized by FDA. We expect the first 2 next month. And those platforms are new vaccine platforms that haven't been used before in the United States, but that doesn't mean that they haven't been studied. CDC and FDA will deploy their routine processes, procedures, and systems to ensure vaccines are safe and effective. We should expect limited doses of vaccine in the beginning and frankly for the first couple of months. Vaccination populations will evolve over time. This is going to be complicated and difficult for all of us, but initially vaccines are going to be authorized and recommended for limited populations and unfortunately only for adults. COVID vaccine planning is changing rapidly. New information will be available soon, and it is a little bit uncomfortable for all of us. We wish we had said information and then we're able to sit back and plan and make sure that we dot all the I's and cross all the T's. But that is not the situation we're in if we really want to take full advantage of these vaccines. So frankly, it's going to be a little bumpy, and we should just expect that. And know that, the training and the skills and the structures that you all have will enable you to manage through those bumps. And finally, you all play the critical role in helping to build confidence in COVID-19 vaccines, but frankly, also in COVID-19 vaccination. I'll stop there, and I think I have a couple minutes for a few questions.
Dr. Messonnier, this is Ryan again. Thank you very much for that very informative presentation. I do have a couple questions that have come in, and actually this question has come in from a couple folks now. You mentioned with the Pfizer drug and vaccine that this would require dry ice and bringing people to the vaccine. Certainly you mentioned that we're up for the challenge. Are there plans for funding local public health infrastructure and flexible funding that reaches local health departments in order to be able to do this?
Yeah, so as you, I hope, know, CDC has provided funding to health departments for influenza and then for COVID-19 vaccine planning. There are additional CDC funds that we expect to be available in December. But I also recognize that what we're asking you to do is extraordinary, and it is on the top of a huge number of additional priorities and needs. And there's only so much that one person can do in one day. We are working with the department on the question of additional funding. For now, what I can say is that what we're trying to do from the federal side is, if we can't give you money, frankly, to give you whatever else we can to try to do whatever we can to help solve the problems. And so we are in daily contact with the health department immunization program, trying to basically break down barriers. For example, for dry ice for this Pfizer vaccine, one of the things that we're doing is actually doing the first resupply of dry ice, which is basically when it gets to you and it can sit in that container for 10 days in dry ice. We're also working on mapping out where you have ultra low cold chain freezers in your jurisdictions, because the vaccine can also sit in those. I wish I had sort of a checkbook that I could say I'm sitting on the money and I'm going to hand it to you, but it's just not the situation that we're in right now. And so, we are continuing to try to work forward with planning and try to document the needs of the jurisdictions and communicate that.
Great. Well, we certainly appreciate all of that assistance, and we appreciate your continued advocacy within the federal government to try and obtain additional financial resources for states and counties. The last question I have is, how will the CDC keep state and local governments engaged and supported within the pandemic's response, but also the other public health priorities that require our attention, such as substance abuse, mental health and suicide, lead poisoning prevention, and beyond? I think you touched a little bit on this in your presentation, but is there anything you'd like to expand on?
I have no magic answers for me. I can't imagine the pressure that you're all in, trying to do your day job, trying to respond to the pandemic, and then also trying to respond to the way in which the pandemic has impacted everything else in health, mental health, substance abuse, lead poisoning prevention. I can't say that I have some specific answer, but I mostly can also say that I completely understand, part of my day job is childhood immunization, and we've seen really worrying drops in childhood immunization in the spring when the stay-at-home order started. And frankly, we have not seen return to normal. We are really estimating that by the end of the year, we're going to have used 9 million fewer childhood vaccines compared to last year, which means many children left unprotected with their vaccinations. We think that that the recovery has actually been faster on the private side than the public side, and in fact, we're seeing worrying disparities in childhood influenza vaccination. I have no magic answers to this, but to really try to get all of our communities and all of our societies together on the solutions. And, I'm sure that you can share the same concerns on other diseases that I don't work on as much, like mental health and substance abuse, but know that CDC and our staff are committed to trying to continue to work with you through these issues. And frankly, I know it's going to be a struggle, and just know that we're struggling there with you.
Well, we're grateful for your partnership and the partnership of the federal government, and thank you so much for taking some time to meet with us. We really appreciate having you on. And at this time, that'll conclude Dr. Messonnier's presentation, but I will remind everyone who's on today's webinar, if you do have questions for the CDC, the federal government, and then certainly our additional presenters who are about to come on, please type them into the question box on the right-hand side of your dashboard, and we will get to those questions at the conclusion of today's prepared remarks. Thank you.
Thank you, and thank you for the time today.
Thank you, Dr. Jack. Can I just make a quick announcement, Jack? Dr. Messonnier, just again want to say thank you very much for all you're doing under these extraordinary times and circumstances, and we greatly appreciate your work from the counties of the state of New York. Thank you very much, Doctor.
Thank you.
Yes, Jack, I just wanted to say just very quickly that Dr. Howard Zucker has joined us from the New York State Department of Health. I don't know if he's prepared to make any responses, but I did want to acknowledge Dr. Zucker's participation in this presentation today. Back to you, Jack.
At this time, we're going to go ahead and move on to the State Department of Health's presentation.
Ryan,
Laura, are you with us?
This is Laura Santilli. Can you guys hear me?
Yes, thank you.
Yes, we can. Thank you. Laura, I think you're back on mute. We just heard you a moment ago, but the floor is yours.
Testing. Can you hear me?
Yes, we can hear you.
I am so sorry. Is this working?
Yes.
Great. Nobody touch any buttons. Great. Thank you very much. Okay, I am happy to join you today to go over the New York State COVID-19 vaccination program and give you a general overview from the state perspective. Next slide. And next slide. All right, so this first slide is just the ability to, in one slide, give you a snapshot of what the New York State vaccination program looks like. So all of these bullets are the topic areas that are covered within our plan and that we are working very diligently to operationalize through more detailed operational pieces of that plan. I'll take a moment through the various slides to walk through some of these pieces. Next slide. All right, we have several guiding principles that are an underpinning to the plan and the program that we have developed and plan to implement across the state. First and foremost, we need to make sure that we are recognizing safety, effectiveness, and the fact that the vaccine is expert approved. We will not endorse or distribute any vaccine until we have determined that it is safe and appropriately effective for the populations that will be using that vaccine in. And we will rely on the advice of our clinical experts and counsel, including the governor's clinical advisory task force that has been appointed for this exact purpose. They will be reviewing and approving every vaccine that is approved at the federal government level to make sure it is something that we are going to be able to use for the populations here in New York. We will also be ensuring equitable and clinically driven distribution of that vaccine. We will make sure that it is focused on those with a higher risk of exposure, high rates of illness, and or a likelihood of a poor outcome, something we're very concerned about here in New York. Transparency. We will make sure all aspects of the COVID-19 vaccine, from distribution and administration, all the data that are available, the safety monitoring process will always be transparent. That way, all of the information that we have available is shared with those that need to know and our stakeholders. Next slide. Data. Everything that we do will be data-driven. Our program from the get-go with our COVID-19 response has been always data-driven, and we will make sure that the vaccine program uses those same principles. We'll be looking at data from the aspects of safety and accuracy and efficacy, as well as on the process side, to make sure that the program is rolling out the way we expect it to, as well as making sure that we meet all of our federal reporting requirements. Safety and privacy is paramount. We will continue to demand compliance, from the public with the COVID-19 safety measures that are already in place. The vaccine will not be the magic bullet. It's going to take us a while to get the herd immunity that we're looking for. In the meantime, we have to make sure we still continue to practice the physical distancing, the mask wearing, and the hand washing. When we do start the vaccination process, we will make sure that those operations prioritize patient safety in those clinical environments where the vaccine is being administered, as well as all of the information systems will continue to guarantee the patient privacy and confidentiality that is necessary. We will continue at the state level to coordinate and direct all of the local resources and assets from the regional and local public health agencies, all the healthcare providers, all of our community organizations and partners to ensure a safe, successful, efficient distribution and administration of the COVID-19 vaccine. Our outreach efforts are extensive, are ongoing, and will continue to focus on those underserved populations and the vaccine hesitant groups to really get to all corners of the state, including the Black and Brown communities where we know COVID-19 has had certainly disproportionate impacts. And as we followed with the overarching COVID-19 response here in the state, we will continue to have that strong leadership and that New York tough mentality to look at it not only with that tough, but strong, united, disciplined, and loving, really carrying forward Governor Cuomo's principles. Next slide. Sorry, next slide, please. Assumptions. Okay. There's a lot that's still unknown about the vaccine program. So in a planning process, we had to make some basic assumptions so that we can continue to move forward. And then as those assumptions are changed or we get new information, we have to make sure that our planning process is agile and can adapt to the new information that's coming forward. At this point, we are expecting to be operational under the emergency use authorization, and the vaccines are expected to be recommended by ACIP. We know that the vaccine supply will be limited in the beginning, so we're planning for that. And so we will focus on our most priority populations, the tippy top, with slicing, the targeted populations into phases that are even smaller, phase 1A, phase 1B, phase 1C, just to remember to match the populations to the vaccine supply. And then as more vaccine comes in, we will then include more and more populations in that. So we are expecting most COVID vaccines are expected to require 2 doses, about 1 month apart. Some are 21 days, some are 28 days. And so having multiple vaccines with multiple implementation methods is certainly going to be a challenge, but one that will make sure that we monitor very closely. We do know that all of the doses that an individual receives, dose 1 and dose 2, must be from the same manufacturer. They cannot be interchanged. So we will make sure that our reminder recall always has the original dosing information attached to it to make sure we can handle the same vaccine being administered to the same individual. Cold chain requirements is really an interesting challenge for our vaccine landscape right now. We know that the Pfizer vaccine is that ultra cold frozen storage requirement, and the Moderna one is frozen and refrigerated. So each vaccine, again, might have different requirements that we will have to handle, and that may dictate, which vaccine administration sites can handle which ones. Out in the most rural parts of the state might not be the best place to send the ultra cold vaccine. We might need to use the more stable vaccine for those locations. And we know that public opinion will be mixed, absolutely. The safety and efficacy, they're concerned about that. And we also expect that misinformation will continue to be disseminated, and our public relations team will be really strong in making sure that we counteract that. Next slide, please. We will make sure, as we have with all COVID-19 response, that we have that strong executive organizational leadership. All of our partners will be key to this. It will be a state-driven, directed implementation response, but it will be all hands on deck. Every resource that's available to us will be tapped into and will be part of our implementation program. Governor Cuomo's charge is to put the best vaccination program in the United States of America out there. That's the way we handled COVID. It's been a model for the country, and we've accepted that charge, and we'll move forward with it. Next slide, please. We are pulling in all of the experts that are in this field to be able to help us with this program. The governor has appointed 2 task forces in particular. One is the Clinical Advisory Task Force, that is those clinical experts from the field, 7 of them, to really look at, as we mentioned, all of the specific details about the vaccine to make sure we are building and maintaining that public trust. From the operational side, we also have about 24 experts on vaccine distribution and implementation to be able to help us and give input and drive the issues that we need to be thinking about on the operational side. And these members also, we were really keen on making sure it reflected the diversity of our state. So looking at the racial, socioeconomic, and geographic composition to represent the local communities that the program will be serving. Next slide. Logistics. As you can imagine, a lot of moving parts. So we have teams devoted to all of the logistics that'll be involved, including the supply chain. The vaccine and some of the ancillary supplies will be provided by the federal government, including some of the PPE to be able to cover, and keep our vaccinators safe. But there will be some things that we'll need to augment or don't have sharps containers, for example, that we need to make sure we are thinking through all of the individual things that we need, right down to the little Band-Aids, to make sure that we have them available in the quantities that we need for the program. In addition to cold chain storage, as we talked about, dry ice capability, transportation vehicles, all of those things. On the call center side, we have a really robust COVID-19 public call center right now, and we need to make sure that we can expand and cover and fully staff and operationalize that from the vaccine side as well. So making sure we have that covered not just for the public, but as well as for the providers who are also going to have many questions and comments, and being able to assist them in this program as well. Obviously, budget is a huge concern. We want to make sure that we have the funding available to purchase and procure all the supplies and equipment, and cover all of the personnel we need to implement the critical operations that we need to put this in place. And then the legal considerations. What do we need to do to make sure either we have to relax some rules or we have to put some new allowances in place to do this in a rapid scaled fashion like this, considering liability issues. What does the reimbursement going to look like? What are the workers' compensation considerations and consent? So our legal team is working diligently on all of those topics. Next slide, please. Public outreach and communication. As I mentioned, promoting that vaccine confidence will be really, really important. News articles like came out in the past week with Pfizer and Moderna coming out with, around 95% effectiveness. We've already seen a little uptick in the question of how many people would expect, to get the vaccine. So something like positive news is very influential to the public. Human psychology works that way. And we can expect that there will be adverse events as well. It doesn't always go well 100% of the time. And that will hit the news as well. And we have to be prepared for that. And we have to be ready with our messaging to say, this is still overarching a really good thing for the public. And we have to be prepared for when those adverse events come out as well, because that will take a hit in the public's vaccine confidence as well. So our team is working very closely with that and will continue to be one step ahead of those messaging. Next slide, please. Data systems. As I mentioned before, data is critical to the work that we do. We will continue to make sure that we have the analytics infrastructure. All of the data systems that we have will need to be able to talk to each other, are interoperable, and will be able to give us the detailed information that we will need to track this vaccine on a daily basis at the dose level. That is the level of detail that we are planning for, and that we have systems available to provide that level of information. Everything from how the providers are enrolling and what the provider profile looks like, to the statistics on the population being vaccinated. What priority group are they part of? What do their demographics look like? How is vaccine ordering and the distribution? We want to be able to track that dose from every point. We want to know where every dose is at all times. We want to be able to help folks with making their appointments, doing the reminders for the second doses, helping them remember the type of dose that they got the first time. So we'll be tracking all of that information, as well as the adverse reactions. Something as simple as a sore arm and a red spot to something more complicated. We'll be tracking all of that and being able to report that on a daily basis. Next slide, please. Operations. Again, as with the logistics, lots of moving parts. From the operational perspective, we expect to not only use our healthcare provider infrastructure, but when enough vaccine becomes available, we would like to get it out as quickly as possible. And so we'll be using the pod scenario as well, which is points of dispensing. These are more high throughput mass vaccination type sites. Again, looking at all of the local resources to keep them as close to home as possible, with all of the support that we can give at the local level, and really making sure from a regional perspective that we have the dispensing capability to match the population of the area. So that will be really, really critical. And then again, keeping track of those underserved areas, how do we push those pods into those neighborhoods that maybe do not have the access or have a bit more hesitation? How do we make sure that we can bring it to them for those that may have some challenges of coming out of the neighborhood? Training and competency, we want to make sure that the staff that we have for all of these operations are fully trained. It is an all hands on deck approach. So we do recognize that we want to expand our authorized healthcare providers beyond just the normal healthcare providers, and looking at other ancillary groups that don't normally vaccinate. And again, our legal team is looking at that to see what would it take to have these folks be able to vaccinate, and what training and authorizations do they need. And then supporting our providers, all of our providers from the hospitals, LHDs, long-term care, all of our community clinics, urgent care, pharmacies, private providers, they're all going to be vaccinators at one point or another. And then we'll actually be looking at some of those congregate facilities, whether it even be schools and colleges, or our group homes for our individuals with developmental and physical disabilities, our corrections facilities. We're going to really get everywhere. So how do we support those providers, make sure they're enrolled so that they're able to participate fully? Next slide, please. Let's try, and there it is, clinical operations. Okay, on the clinical side, we talked a little bit about this, really monitoring that vaccine safety and efficacy. This is even at the time we received EUA, and even moving through the licensure process, as well as post-administration of the vaccine through our VAERS system, the Vaccine Adverse Event Reporting System. From the prioritization perspective, as we talked about, we have to identify those critical populations and kind of put that priority in order. As the vaccine supply increases, we'll be able to move down those population groups, starting with the healthcare providers and the most vulnerable, moving all the way down to the general, otherwise healthy population. We need to be flexible, and depending on how the vaccine comes out, that's how we will have to adapt to the different cold chain requirements, or potential certain populations that it's authorized for and certain populations it won't be. For example, pregnant women at this point have not been part of the clinical trial, so their approval will probably come later in the process. So we need to keep those types of criteria in mind. And again, making sure our providers are comfortable with all of the nuances about the vaccine. What are the contraindications? Who should get it when? So making sure that clinical training supports our providers, and focusing on those special populations to ensure that we have the health equity and we do not continue the disparities that we've seen with the COVID illness. Next slide, please. All right, just a couple of slides on the federal approval process. We do know FDA has issued guidance to the industry about vaccine development, and the criteria was that it had to be 50% effective. The first 2 vaccines blew that out of the water. That's fantastic. We are so excited about that. We know that the phase 3 clinical trials needed to include 30,000 volunteers, and again, all of them are moving towards that. The trials also included racial and ethnic minorities, and we are really happy to hear yesterday that the vaccine is also effective in the older population. That's always a concern with vaccinations because of the makeup of the immune system as adults age, but we are hearing really good vaccination success in the older adult population as well. So we want to see the same across all of these underserved populations and our racial and ethnic minorities. And then the revision in October was that the participants needed to be monitored for at least 2 months. And so that pushed the timeline just a little bit, but did give us some extra monitoring time, which is really important for maybe those delayed effects. Next slide, please. So we do know 2 different groups will be advising on the vaccines. So the first one, the Vaccines and Related Biological Products Advisory Committee, they advise the FDA. And their recommendations are not necessarily binding, but are usually followed by the FDA. So we do expect that that expert group will continue to be guiding the FDA. And then ACIP, the Advisory Committee on Immunization Practices, is an independent advisory group to the CDC. And they're the ones that will be making the recommendation about the use of the vaccine, and they break it down. And they do this every year by children, adolescents, and adults. So they will continue to make those recommendations as new information comes out. They may change their recommendations based on how the vaccine landscape changes. Next slide. What does ACIP take into consideration? Of course, they take safety and efficacy. They look at it from various age groups and high-risk populations. They look at the severity of the disease and the frequency of the disease. And then they look at those practical matters. What does it look like from a cost perspective? Is insurance going to cover it? How complex is the schedule or the dosing, regimen? How can they take health disparities, social justice, and accessibility criteria into consideration? And really, what's the acceptability to the recommended population and healthcare providers? So they have committed to convening their group within 24 hours of an EUA or licensure down the road. And so we can expect to see their information come forward very quickly. Next slide, please. And this is just to break down a few of the terminology that you may hear. A vaccine EUA, an emergency use authorization, is the phase that we're in right now, and it is often appropriate in emergency situations like we have. Once studies have demonstrated a certain level of safety and efficacy, and this occurs before the full formal FDA review and licensure. That's the next step. So the FDA would then fully license a vaccine to be used and would detail very specific circumstances. So there's EUA, which is an authorization, there's an FDA license, and then there's an ACIP recommendation. And the ACIP recommendation usually gets more specific than the FDA licensure and really calls out where differences may be in place for different groups and could potentially recommend a certain type of vaccine for a certain type of population. So we'll be looking forward to that. But this should help you keep track of all the words: authorization versus licensure versus recommendation. Next slide. I believe that is it. Yep, happy to turn it over to Sarah.
Would you like me to go ahead, Stephen?
Thank you very much, Sarah. Thank you very, very much. And thank you, Sarah, for all that you have done the entire year and the past several years, and all the great work of the county health officials in cooperation with the State Department of Health. Please, Sarah.
Thank you. Good morning. It's an honor to accompany the prestigious speakers on today's panel. I'm feeling very humbled and grateful for the opportunity. So thank you to NISAC for including us today. My name is Sarah Ravenhall. I'm the Executive Director at the New York State Association of County Health Officials, representing the 58 local health departments in New York State. Next. Our association, which you may hear referred to as NISACHO, is the collective voice for local health departments throughout New York State. We've been serving our members since 1979, providing technical assistance, training, advocacy, and policy influence. NISACHO works closely with the New York State Department of Health to strengthen communication between state and localities, Since the start of the pandemic, we've developed a framework for our members that allows them to provide enhanced pandemic response and information sharing with peers across the state. We're providing 24/7 support by answering any questions our members have, guidance interpretation, regulatory review, member meetings, calls with the state, and more. So our office right now is all hands on deck alongside our members and the counties during this time. Next. Vaccine distribution has been a key component of public health responsibility undertaken by local health departments during disease outbreak. In addition to conducting disease surveillance, contact tracing, supporting those that are under quarantine or isolation, local health departments are skilled at emergency preparedness and medical countermeasures in an effort to provide mass vaccinations or distribute medications. So the photo here was taken in 1954. It shows a group of community members in Laredo, Texas, and they're receiving their typhoid immunization. So this is evidence that vaccine distribution is a public health intervention, that we've been at the helm of this work for many decades. Next. This is my disclaimer that I am not an attorney at all, but I wanted to provide resources and legal references that are applicable to sections of public health law that may be relevant to your counties as you embark on this vaccine distribution mission. So here you're going to find general New York State public health law that covers county requirements related to immunizations that would be relevant for COVID vaccine under the current statute. And just to note that Public Health Law Section 2168 is directly from the Department of Health website, not actually in statute. So your county may want to review these sections of law if you're not already familiar as you prepare for vaccine distribution events. So if you'd like a list of these references following the presentation, I am happy to share. Next. Okay, through the federally funded public health emergency preparedness contracts, local health departments engage in a myriad of drills, tabletop exercises, and other planning efforts that are critical for emergency preparations and sustained through public health emergency. During the pandemic, we have heard routinely from our members that over time, these annual drills and events have truly poised them to feel confident in their ability to respond swiftly and efficiently during pandemic response. One of the key updates outlined in these deliverables is updating their point of dispensing plan or their pod plan on an annual basis. So counties have this plan ready to go at all times, which is so critical to New York State's collective ability to protect communities. Just in the last few weeks, local health departments have enrolled with New York State to serve as provider distribution sites. They've assessed if there's ultra cold storage capacity in their community, updated their pod plans using a state template that was provided to them, and they're continuing to enlist volunteers in their medical and non-medical reserve corps. Next. Okay, so as you'll hear reiterated in this presentation today, counties stand ready and prepared to work with the state and serve as local operational extensions into the communities when it comes to COVID-19 vaccine storage and distribution. Will this be a heavy lift? Yes. Will we need state and federal support? And the answer is yes. I'll talk about that later, but here are some examples, and I was hoping they would go one at a time, but the first is Livingston County running a COVID testing drive-through event. So I'm sorry, they are covered at this moment. Yes, thank you, great. Okay, so that's Livingston County. The next photo is a pod mass vaccination in Nassau County, 2009 around. So I'm guessing this is H1N1, and you all probably remember the response efforts that were needed during that pandemic. And then the third is Jefferson County. They recently ran a drive-through flu clinic for other Jefferson County employees by appointment only. And this was practice for COVID-19 vaccine, which will, come in the next few weeks or months. Next. Okay, what are medical countermeasures or MCMs? MCMs are products, vaccines, antivirals, medicines, antidotes that need to be distributed to communities in the event of a public health emergency. As we heard today, there's still information pending in terms of what the flow of how these COVID-19 vaccines will be dispersed, but we're going to hear more and more about that from the CDC, from the manufacturers, and from the state, and we're hearing more each day. So we'll soon know how this will truly operationalize at the local level soon. Next. What are pods, or points of dispensing? So pods are events that are held to allow for mass distribution of MCMs. The local health departments hold these events with their staff, elected officials, intergovernmental partnerships, volunteer corps, and community partners to ensure product is delivered. And there are two types of pods. Open pods are located at public areas, arenas, community centers, schools. They're operated by the local health department, and they dispense MCMs to the public. The closed pods are managed by the organizations that are hosting them. Usually the local health department is involved. It could be public or private, and they dispense MCMs only to their own populations. Typically, these two types of pods take place concurrently to supplement one another. So for example, a closed pod may be taking place at a healthcare facility where a healthcare worker receives immunizations. And the photo here shows Oswego County drilling their pod plan using Girl Scout cookies to simulate pod distribution efforts. So although it's Oswego in the picture, this drill included a regional representation from 9 additional counties. So truly a regional and collaborative effort here. Next. So who are our partners? This is not a comprehensive list, but counties know their partners. They have well-established relationships with them. Local health departments have included relevant partners within their pod planning efforts, and they're able to support them during vaccine administration and outreach. Next. Okay, the pod plans also recognize health equity and strategies for reaching those populations living with a disability, vaccine hesitant populations, transient or homeless individuals, anyone who we know needs to be reached in a non-traditional way to ensure that there is access to the product for them. Governor Cuomo has talked frequently about ensuring that there's vaccine delivered to Black and Brown communities. This is something we absolutely support since data shows they are at a higher risk for rates of mortality. So that's very critical here. There are all other groups who are looking at as well. So some counties may have special populations within their borders or large industries that employ a majority of the population of that area. So these are all considerations that the local health departments take into account and will support, which is why it is so important to request for flexibility, which will allow states and locals to prioritize vaccine distribution based on the localized needs of their community. Next. So Laura already went over the New York State plan, but the specific areas where local health departments are pointed out in this plan really include storage administration of the product, implementing their local plans, so their pod plans, building public trust, working with community providers. So these are broad strokes. There's going to be a lot more granular work that's involved, of course, depending on the local health department's capacity and community need. Next. Another disclaimer, I'm not an attorney, but as we prepare for mass vaccine distribution, counties and county attorneys may want to review the federal protections that are available to providers. So the PrEP Act authorizes the Secretary of the U.S. HHS to issue a PrEP Act declaration that provides immunity from tort liability, excluding willful misconduct for claims of loss caused, arising out of, or relating to, or resulting from administration or use of disaster countermeasures. There's a fantastic sheet available on the CDC website that you can download. But another suggestion is that your county attorneys review your county plans for health, safety, and security protocols. Next. Okay. As one of the most monumental initiatives of this pandemic, more funding will be needed imminently to cover the cost of vaccinating 20 million New Yorkers. It's a heavy lift. Local health departments have been using FEP funding, Immunization Action Plan funding. At this time, Commissioner Zucker, hello, Dr. Zucker, declared an imminent threat to public health with reimbursement now being set at 50% beyond base grant amounts for Article 6. This is not going to be enough. I think that the state has said that they have the fiscal task force that is looking into this, the fiscal group that's looking into this. But we certainly look forward to seeing more information about federal and state funding that will be used to support these activities. And you saw that on September 23rd, HHS announced $200 million from CDC to jurisdictions for COVID-19 vaccine preparedness. Next. So some of the challenges that we need to prepare for: funding availability, and not only availability, but ensuring that the funding is flexible, not restricted in terms of how it can be spent. As community strategists, we should be trusted to utilize any funding in the way that is most reflective of the populations we serve, which will allow us to work more efficiently. It's critical that we continue to protect, support, and reinforce our public health workforce. They're stretched very thin right now. They're taking on new mandates almost daily, and they're seeing an increase in cases right now. We're all seeing it. Not to mention the staffing has deteriorated over time. So we've, since 2011, seen about a third decrease in the public health workforce in New York State. We're also seeing early retirements, and we're at risk of collectively losing decades of public health expertise on the local level. Vaccine hesitancy can be addressed through building community trust, working with community leaders, and sharing evidence-based information about the safety and efficacy of vaccine products. On the other hand, we have to think about the groups that are opposing vaccine. They're very well organized and vocal, so counties should be prepared for that when thinking about security measures during their pod events. As we heard today, each of the vaccine products are a little bit different from one another, how they need to be stored or administered. So we do anticipate challenges with the various products and keeping that organized, but we'll learn more and adjust as we move forward. I think the key to these challenges will really fall in the partnership that we have with the federal, the state, and the local relationships, and continuing to work collaboratively in all areas of pandemic response. As a member of the Governor's New York State Task Force, NYSHO and local health departments are represented in the decision-making process. So we're already feeling confident about our relationship and ability to work collaboratively with the state, and we thank them for all that they do. And of course, the leadership, New York State local elected leaders have provided to their local health departments has been monumentally important in supporting the local health departments and inspiring them to continue working. We must continue to have conversations about protecting public health and ensuring staff time for local health department work is covered at 100% of the cost of the life-saving work that they're doing. Next. Thank you again to leaders working locally to protect the health of communities and support their local health departments, and to the state and federal partners who are working so hard to drive the ship and for trusting the expertise of the localities on this important initiative. NYSAC has been an incredible partner to NYSHO during this pandemic. We can't thank you enough, President Jack Marin, the NYSAC board, and Executive Director Stephen Aquario for their leadership during this time. Thank you.
Sarah, thank you very much for that informative presentation, and we concur 100% with you. We appreciate the partnership with NYSHO and NYSAC and NYSHO. We share the same membership, so we'll continue to be working with you and partnering with you to make sure that we deliver this vaccine and the public health work that your members do and the counties do across the state to ensure that the public at large is healthy and protected going forward. We do have several questions. I want to jump right into it for both our state and local representatives. I'm going to start with the first question, and I believe this is it's a tag question. And Laura, if you're still with us, this is a question for New York State, and Sarah, please feel free to chime in as well. For the military communities, will vaccinations be handled by the federal government, or will it remain the responsibility of the state or local public health department? Can you talk about how vaccinations will be done for the military communities?
Hi there, yes, this is Lori. Can you hear me okay?
Yes, we can.
Perfect, thanks. So yes, we are working very closely with the operational partners at the federal level. At this point, we do expect that the feds will deliver directly to the DoD facilities. but they will be sharing any that potentially are not part of that direct distribution, so that we at the state level can make sure that we cover them. So yep, that's already on our radar, and most of them, we're being told, will be direct ship from the federal level.
Terrific. On a similar note, what are the plans for handling outreach to the Amish communities? And maybe I'll tag on to that, some of the other communities in New York State, tribal Indian nations, and other groups that may or may not have easy access to communication in the traditional sense.
Yep, absolutely. Both of those groups are in our planning process. I'll take them backwards, starting with our tribal nations. Because there also is the Federal Indian Health Service program, we've had very strong communication with our tribal nations, those that are federally recognized and not, because again, like the DoD facilities, they have the ability to receive directly from the federal government. But we give the autonomy to the nations to choose how they want to receive their vaccine, whether they want to choose to go through the federal program or through the state program. So a lot of communication ongoing with our tribal nations. The same with our various religious communities, both the Amish community as well as some of the other really stringent religious communities, to make sure, one, they have the information they need, and two, that they're captured at the local level. These are groups that we work with all the time, especially in the vaccination programs that we have, especially thinking through the measles outbreak that we had, in the Jewish community. A lot of communication, a lot of relationship building with those groups, and then in the Amish community as well. Out in the local communities, they know these communities really, really well. They have those established relationships, and that we will definitely be capitalizing on those relationships for this effort as well. So they are all in our planning process under our special populations work group.
Laura, thank you. And before I shift gears, one last question on specific populations. Will New York State prison populations be the responsibility of state? I'm assuming it might be partnered between DOH and docs. Can you talk a little bit about that?
We can. The state agencies, we have a special work group pulled together for all of our state level agencies that have local populations. So for example, prisons with docs, and then jails with SCOC. So they each have a parent organization, so to speak. So we are working with the parent organization as well as the local level. So that's on corrections. And then taking that same philosophy with some of the other state agencies. So like OPWDD, for example, has the group homes for the individuals, with developmental and intellectual disabilities. And then we have OTDA with our shelters and covering our homeless population. We have OMH with our mental health facilities, OASAS with our rehabilitation, drug treatment programs, things like that. So all of those agencies are part of this statewide response, and will be, again, amassing all of that knowledge and resources to have one coordinated, directed program. That way everybody knows who's doing what, the roles and responsibilities are clear, and we're not stepping on each other's toes. So it's going to be coordinated and directed to make sure we don't have any time for missteps. So, yep.
Great. And then I have two questions here on the CDMS system. I'm going to combine them and ask them in one question here. Does the state believe that the CDMS system will be adequate enough to track and schedule vaccinations? Or is New York State looking to do a system more in line with what Salesforce has presented earlier?
We do at this point expect to rely on a complementary group of systems. So like the healthcare providers, they normally, especially like our pediatric and adult vaccination providers, they use, when it's in upstate, the NICIS system, the immunization information system. And then down in the city, they use CIR. Those systems talk together. when we look at those community-based pods that I was talking about and Sarah delved into a little bit more, that's where the CDMS system comes in, because it's not usually in a healthcare provider environment. So it has been very effective, and all of those systems talk. So CDMS feeds into NICIS, NICIS is connected to CIR, and all of those will feed into our dashboard. So we do feel like we have the structure we need, but of course, you know, is it scalable? Is it going to be able to maintain, you know, the intensity? Those are the things we are absolutely making sure, you know, we're doing those tests now to make sure that we, you know, can load test. Can we handle that scale? And is the system going to be responsive? So yep, that's definitely part of our work as well.
Great. Thank you. I want to shift the focus a little bit towards educational material and outreach. There's a couple of questions in this realm. Is there, and Laura, I hate to keep asking all the questions to you.
It's okay. I'm used to this. No worries.
I think you might have
Sarah's
the
membership
answer.
grills me every Wednesday, so I'm good.
Is there, so to speak, a toolkit for vaccinators as to the storage, handling, preparation, and the administration of the vaccine? Is there any kind of a toolkit that's being developed?
Yeah, there will be. It really is vaccine specific, right? So we at the state level, Pfizer and Moderna have been very forthcoming with the information so that we can prepare, doing webinars for us, doing videos, and we will then be pushing that information, you know, downward as well. It's fantastic what they're doing. We don't have to make any changes at all. We can really just push it right down to our vaccinators, and then just adding if there needs to be anything that is a New York local flavor, something specific, you know, that we have to make sure we include. But it looks really good so far for Pfizer and Moderna, and I would expect all of the other companies will be doing the same. So.
Great. So the next question I have is, are there any promotional materials specifically tailored to communities of color and other marginalized groups that are going to be sent to local health departments? There's some concern that, you know, LHDs, all their staff right now are being tied up into tracing, isolating, reaching out, doing, you know, contacts to individuals who are sick to make sure that they're doing okay. Is there going to be some kind of a design and pilot test messages that will be shared for reaching out to these targeted communities? I guess this kind of goes back to how you were talking about the Amish and those kind of groups as well.
Yeah, absolutely. Our Black and Brown communities, especially, you know, the past, you know, several months with all of the social justice awareness, you know, coming to light, we would be foolish to ignore and not highlight, you know, that issue. Our public relations team is fantastic. They are working right now. I believe they are ready to share their first cut of what they have. So I think we're just now at the point of, you know, reviewing some of those first cuts. So, and doing those focus groups out into the community to say, hey, how does this look? What do we need it to say? A lot of work being done right now. It's right on the cusp. I'm going to make sure that they do have, you know, that message to come back that, you know, you folks would definitely be interested in looking at it and providing feedback, you know, before it goes live, so to speak, because that local experience, you know, I think they would be really interested. And I'm pretty sure they have it as well, but having another set of eyes is not bad.
Great, thank you, Laura. I want to jump into some specifics on the vaccines themselves right now, both the Pfizer and the Moderna products. Who determines which vaccine will be distributed where in the state? How's that going to work?
So the right now we're getting estimates from the manufacturers as to what their production rate will look like in a month, right? So for example, Pfizer has said they can probably do 20 million for the nation for United States. Okay, so I want to be clear because Pfizer is also doing some work with others. Ooh, I see Stephen is, oh, okay, check the phone. Okay, sorry, I thought you were trying to give me a note. You're giving somebody else a note. So the The Pfizer vaccine will have an allocation at the federal level, and then we're hearing from the federal level that it will be pro rata, so by population to the states. And then what we will do at the state level is we will then, using our priority population, so like we had mentioned, healthcare workers are going to be number one, they're group 1A. So of course it makes sense that we would ship that to the hospitals first, right? Because that's where the healthcare workers are. And even if we don't have enough to cover healthcare personnel broadly, both in the hospital and out of the hospital, we know the hospitals would then be the subgroup of 1A, right? It really depends on how many doses we get, because then we may be saying, okay, ICU and emergency department staff get it week 1, right? So we may have to slice and dice into the teeny tiny little groups, and we will make sure that the vaccine, we, the state, will direct the federal allocation directly to the administration sites. We're going to do as much as possible to not have too many vaccine hops, especially with the cold chain requirements. So the idea is to get it from the manufacturer or their distribution center directly to the site of administration within 24 to 48 hours so that they can get those doses into arms very, very quickly. Within 10 days, we want that first bucket to be in arms.
Okay, great. One quick question, and then I'm going to go to Stephen, who has a question he would like to ask. On the vaccines, when is it anticipated that children will have access to the vaccine?
Yeah, the clinical trials, they drill down, right? They start with, there's very few parents that are probably going to sign their kid up for a clinical trial, right? They know that. So so most of the clinical trials start with, general adults. Because of the different considerations that we had with the older population and racial and ethnic minorities, the vaccine manufacturers were directed to include those populations right off the get-go. They normally don't, right? So they normally take time to do these clinical trials, and they do it with this group, then they expand it to that group and that group and that group. So we have accelerated by mixing the population in the clinical trials sooner. Pregnant women and children, because of their uber sensitive, criteria, are always later, but they will now start to enroll those as well. Now that they have some of that initial safety and efficacy that shows that it's safe, now they will move to some of those special populations. So it will be a little bit later, right? Because they have to wait for the clinical trial data to come out, but they will be included eventually.
Okay, great. Stephen, you want to ask a question? Go ahead.
Thank you, Ryan. I just wanted to acknowledge and thank Kristen Proud from the New York State Department of Health Commissioner's Office. Thank Dr. Zucker, and also acknowledge and thank Dennis Whalen of Northwell Health on Long Island and the massive healthcare system on Long Island, and offer an opportunity to both Kristen and Dennis if they wanted to share any observations, thoughts, questions, comments, and concerns before we adjourn this session today.
Thank you, Steve. Obviously, you can understand this is a massive undertaking. And as several people have noted, it's all hands on deck. It starts out, as Laura has noted, with a constrained supply, but will quickly ramp up and more vaccine becoming available until we are doing something, similar in mission to what occurred in the 50s and 60s with the polio vaccine, but it's going to be at a much larger scale. And so that brings with it lots of challenges, and this will not be able to be done without counties. You are the bedrock of us reaching across the state into all communities. You possess the knowledge that is closest about how to reach particular populations, and so we look forward to this as a partnership that will exist and carry through the marathon, because it really is a marathon with several sprints located in between.
Thank you, Dennis. I appreciate your expertise, your knowledge, your insight, your partnership and everything so that we can get through this. Kristen, did you want to add anything from your perspective?
Hi, Steve. Yes, thanks, everyone. So I just wanted to thank the counties for their tremendous partnership to date. This is a critical next step in containing the virus, obviously, but I think we would be remiss if we didn't thank all of the counties and the local health departments as well, under your leadership, Sarah, for the tremendous efforts that have been done to date to try to manage the public health emergency as best as possible. It's been a huge effort, obviously, all the testing, all the tracing, everything that has gotten us to this point. And I think we are, on the cusp of a pivotal time in managing the public health emergency, both with regard to the vaccines that are on the near horizon now, hopefully, with the exciting news in the last 2 weeks, particularly from Pfizer and Moderna, and also with the therapeutics that are coming in as well. We've had remdesivir since early May. We now have banlindivimab, which is Eli Lilly's therapeutic. So this is clearly going to be a multifaceted approach to continuing to manage and eventually, hopefully, contain the virus, right? Testing, tracing, those are going to need to continue as huge elements of this throughout. And so I want to just emphasize that while we're all trying to figure out the vaccine implementation plan as best we can, given what we know now, and obviously we all collectively have still, some gaps in what we know, just because there are a lot of uncertainties that remain at the federal level. All of the other efforts that have been stood up along the way since this began in March really need to continue in earnest as well. So thank you in advance for the continuation of those efforts and for our ongoing partnership.
Thank you, Kristen. Thank you, Ryan. I'll turn it back to you, Ryan.
Great, thank you, Stephen. We do have a few more questions, but I think what we'll do in the interest of everyone's time is we will, it looks like most of them are for the State Department of Health. We'll follow up with those in an email. Before we conclude today's webinar, I do want to again thank Maureen Hagan, Regional Vice President at Salesforce, and the entire Salesforce team for sponsoring this webinar. Again, thank you for that. And I would be remiss if I didn't acknowledge and thank our partners at the CDC, the Department of Health, and of course, Sarah Ravenhall and the terrific team at the New York State Association of County Health Officials. So with that, that'll conclude today's webinar, and thank you all very much for participating. Copy of today's slides and a recording will be available on the NISAC website at www.nisac.org/webinars. Thank you.
Thank you.